somebody has any questions for Dr. Bowes, we'll have the chat room open and see on YouTube. And the YouTube is at Wisdom Table at Ghcr.Nyc in today's date.
Got it.
Okay, so I'm looking at it on YouTube right now, so it's up. And the chat room is open, everything's ready.
Okay. And this is the Wisdom Table coming to you from Grand Houses Community Radio based in Harlem, USA. I'm Brother Leroy, co-host along with Sister Dr. Others, Sister Shirley, Sister Eva. And the purpose of the Wisdom Table, ladies and gentlemen, is to present information that otherwise would not be getting to the general public and definitely not getting to the Black community. And the program does not reflect the views, attitudes, whimsies, or any other proclivities of the resident association here at Grand Houses, nor does it reflect any of the views of the management of this NYC development. But the program does reflect the research done by the participants in this program, and that means you, ladies and gentlemen, brothers and sisters, boys and girls, you are obligated to do your own research after you hear this broadcast to prove out or to disprove what you hear. And if you find anything in error, of course, come on Black, and we will rectify it. Our guest is our favorite doctor, go-to doctor, and we've been interviewing her for quite some time over the years, starting at WHCR and now on Grand Houses and also James Weldon Johnson Houses independent radio station. Dr. Belva Bowles, thank you for joining us today, April 8, 2020.
Well, thank you so much for inviting me. This is my joy.
And the reason that we've invited you is for you to give us an update. An update means that based on your readings and your own particular experience, that you can give us further insight into the coronavirus, otherwise known as COVID-19. And we have a wide range of questions, of course, but let's start at the very basic, point, and that is, please define virus, please define bacteria, please define germs, please define how flu works, and quote, how a virus works.
Okay. A virus such as COVID-19, and what a lot of people seem to be confusing, a virus is not alive. It is a particle. It either is a DNA or an RNA, and sometimes in rare cases, a protein particle. Just to bring that home visually, if you were to shake salt crystals on a table and take your finger and pick up a single crystal, that would be a good example of what a virus is like. The reason I use a salt crystal identity, when you pick it up on your finger, it's just a hard crystal. But if you were to touch that to your eye would start burning, it would turn red, and it wouldn't be comfortable, because that crystal or that particle makes the eye do something. And in the case of a salt crystal, it makes the concentration of the fluid of the eye too salty that then gets a response. If you were to take the salt crystal and place it inside of your nose, mucus would start to run. You'd have a runny nose. If you put the salt crystal in your mouth, you would taste it very salty. A virus acts a lot like that. It is a non-living particle that you can pick up on your hand or breathe it into your nose. And once it is in the nose or in the eye, if you rubbed your eye, it's like the salt particle. It makes the body respond. The particle will cause the cell to take it inside. In other words, it gets attached and then it gets engulfed. Once it's engulfed inside of your cell, whether it's a cell in your eye or a cell on your nose, a cell in your mouth, it takes over. It essentially demands that that cell, whichever it was that engulfed it, does only by directions that it gives by the DNA or RNA that's contained in the virus. So consequently, a single virus that gets into a living human cell can start commanding that cell to replicate it. So you get lots and lots of new viruses made by the very cell that got infected. And when that cell makes enough viruses, the virus causes the cell to rupture. Now you have thousands, hundreds of thousands of viral particles released into the bloodstream or the lymph system. And that's what they mean by you are now infected. You're the single or maybe a few viruses you picked up from the outside was successful in commanding cells in your body to create more viral particles. So that's why viruses are so hard to interrupt. The only things you can do to stop viral infections are three things. You have to stop the attachment. And that's why they say wear a face mask. Why? You're protecting your nose from breathing in any particles in the air. You put a mask on, excuse me, so that you're not spreading. If you are a carrier, you're not spreading any particles when you cough or even speak. Why do you have a face shield? You'll see in the grocery stores now they've put a shield between the cashier and the person getting groceries. If you saw on television with people in what they call the PPE or personal protective equipment, many of them have face shields. That is to prevent any particles that is being sprayed because you're talking, coughing, sneezing. It cannot land on your face or near your eye, your nose. So that is preventing the first step, which is attachment. That's why you wear gloves. You're preventing attachment. The second thing is when the cell gets to the eye or the nose or the mouth, that's when your second mode of invasion happened. During the time a virus is invading a cell, how do you know? Your throat gets sore. You find yourself going, you can't clear your throat. Sometimes the soft palate in the back of your mouth feels tender or sore. I've heard recently one of the symptoms is you lose your sense of smell. Many times when you lose a sense of smell, you lose your sense of taste. Some people report extreme fatigue. They just can't get enough rest. And when they get up, they're still tired. That would be stage 2, where the viral particle is literally invading the cells of your body. Can you do anything to stop it? Yes. If your throat is sore, soft palate is tender, gargle. Gargle with warm salt water, gargle with mouthwash that's recommended for cleaning the oral cavity. If you have a neti pot, and that's spelled N-E-T-I, any holistic medicine person knows about neti pots. You can literally rinse the inside of the nose. People who have severe allergies or sinus infections use the neti pot even when they're not worried about viruses. They wash out pollen and other things. So you can interrupt that second stage of invasion by gargling, by using a neti pot, and there are certain kinds of lozenges. I'm sure you've seen the chloroseptic sprays. You may have even seen the menthol type lozenges, but the most effective against the virus have been found to be zinc, and that's zinc gluconate. It is usually a melt away kind of lozenger. Zinc is a mineral that helps to protect the living human cell. It doesn't allow the virus to get inside of it. In other words, it gives you a little added armor. That's the proposed mechanism of action. Zinc also helps you heal faster. So there's something in our immune system that recognizes that mineral to protect and to hasten healing. So zinc is highly recommended for healthcare workers or people who are exposed. Use it as a lozenge. You can take it as a supplement. The natural food with high zinc would be oysters or Brazil nuts. So you can supplement your immunity by eating the right kinds of foods. The third stage of a viral attack is infectivity. And the infectivity is after the virus has attached, after the virus has been taken into a living cell, after the virus has replicated or multiplied itself, and now that cell ruptured, and you have 100,000 viral particles circulating through your blood. Now you are infected. And that's when you have fever, headache, fatigue, loss of appetite. And the thing about COVID-19 that is what is the biggest scary part to ER docs and hospitals is this virus targets a receptor in your lung. Now, all of your body is infected. That's why your muscles ache. That's why you feel sore. The muscles are getting affected. That's why you can't think. That's why you have a fever. But this virus seems to target very rapidly the lower part of the lung. And as it goes rapidly to the lung and starts latching onto receptors, the body tries to fight it by producing mucus. And as we know, as mucus is in the lung, you can't have oxygen in the lung. So the more intense the infection, the more rapidly we produce a mucus. And this mucus can turn into a plug. It can cause the cells in the lungs to swell. I heard a young emergency medicine doc in New York describe it's more like ARDS rather than pneumonia. And that's a technicality to medical people. But what it says is if it's more like ARDS, lung tissue gets destroyed by the virus and not just glue it up with mucus. And the suggestion is the ventilator may or may not save your life. And that's why you want to make a distinction. Is it causing pneumonia or is it causing ARDS? And that decision, to my understanding, has not been determined. But that's why you hear people say, went to the ICU and 24 hours later they're dead, or went to ICU and 3 days later. The rapid effect of this virus is it specifically targets a receptor within the lungs and acts rapidly. So 3 ways that the virus can be mitigated from the health position. We can stop it from being attached. Wear your glove, wear your face mask, wash your hands, be aware of your space when you're talking or in an area with other people. Stop attachment. Wipe off surfaces, the table, the handles, where you sit, and so forth. That's preventive for attachment phase. Number 2, you have been exposed. You have a sore throat, you're starting to feel tired, gargle often. If you have a neti pot, clean your nasal passages. If you have access to high zinc compounds, high vitamin C foods, high vitamin D foods, start supplementing, boost your secondary immunity. If after all that you have the infection, what does that mean? High fever, extreme exhaustion, dry cough. That is the point where you are now getting into trouble, meaning you may need support from an emergency medicine or even an ICU unit, because it says the infectivity can get your body to respond in such a way that the response itself can do you harm. So you don't want to try to stay at home and tough it out. If you're high fever and coughing and having chills and can't quite catch your breath, you need assistance. So that's the story on a virus. When we talk bacteria, bacteria is a living entity. It can live in water, it can live in soil. It doesn't require a human to exist. The viruses require a living cell to exist. Bacteria lives all by itself. So consequently, when we say antibiotics, we can kill something that's already alive. So I can devise some kind of treatment that can kill a bacteria. But whenever you're devising a treatment for a virus, you are really killing your own living cell in the process, because it's the virus that hijacked your cell. So that's what makes it so difficult and so tedious. And that's why they tell you we don't have medicines against the virus. We do antivirals, but it has to interrupt one of the three things that I told you. It has to interrupt attachment or invasion or infectivity. It doesn't, in terms of life and death, kill a virus. It can just prevent it from manifesting in our body, creating disease. So COVID-19 is a very ancient virus. While coronavirus is an ancient virus. The difference in COVID-19 is this virus has now infected man. It obviously has been around in animals, but as of October 2019, there was the first time they saw the cross from human infection and animal infection. But it has always been around. This is not new. That's why the news media had to stop saying it. They were saying this new virus, and suddenly the medical profession and the zoology profession, microbiology said, this is not new. You need to tell the people the truth. So that's why they changed it to COVID-19 to say, this is a coronavirus in 2019 that's behaving like this. But corona is not new. It has been around. The common cold is a coronavirus. Does that answer the question?
Okay, how does the flu work?
The flu is also a virus. It's an influenza. See, we have a whole bunch of viruses and HIV is a virus, herpes simplex is a virus. So virus is a very well-known entity in the microbiology and infectious disease people. When you talk about influenza, you notice you have to get a shot every year. The reason that the influenza vaccine is yearly is the same reason why it's so difficult to find out how to treat COVID-19. Viruses modify when people get it. Let me give you an example. If I were given a blueprint and they said, okay, Velva, build this chair. And then they gave my brother a blueprint and said, okay, build this chair. We would both follow the blueprint, but I might do something just a little different. Maybe I use screws instead of nails. Maybe he would use a mortise joint instead of the screw or nail. And we both would produce the chair, but those little differences are the kinds of modifications that viruses go through. When it gets into my body and tells my cells replicate this virus, whatever my cells may have a little change, it replicates. It may make 100,000 viruses, but the virus it made may be just a little different from the virus that my brother makes. So consequently, if you're trying to vaccinate someone against a virus, if you use mine and develop a vaccine, it may not work when the virus my brother makes is exposed to that same person. So vaccines have to be very specific, and viruses are notorious for being just little modifications every time it goes through a host. And that's what we mean by a host. If it infects people in New York, by this time in June, the corona or COVID-19 that's in New York may be just a little different from COVID-19 in California. Why? Because the people that the virus is using as a host may just modify it a little bit, because that's the nature of replication. So viruses, is very hard to have a vaccine because every host allows that virus, when they go through the infectivity stage, to modify, and some will say mutate, just a little. And that's why we haven't found an HIV vaccine. The same thing applies. Every host, it slowly changes the characteristic of the virus itself. So a vaccine that you may create, say today, may not work a month from now, because of how many hosts will have now had the virus go through them.
Okay, just review with us. The person has this condition. They go to the hospital and they're given, or a private doctor, they're given an antibiotic. What does that do in terms of those three stages: attachment, invasion?
Oh, well, we don't have a medicine for you. If you go to the doctor now and you have a high infectivity of COVID-19, they may do the following. They may give you a dose of steroid, and the steroid would be trying to slow down your own body from producing too much mucus. Remember, I said your cells get hijacked.
Right.
So the virus is attaching and hijacking your lung cells, and your natural response may be produce mucus, produce mucus, produce mucus, because that's the defense. But if the mucus is the reason you can't get oxygen in your lungs, the treatment would be reduce the amount of mucus. So we treat symptoms. We're not killing the virus. We're not treating the virus. We are trying to keep ahead of what can kill you. So I may give you a steroid to slow down the production of mucus. If you are developing fever, I may give you an antipyretic to keep your temperature from getting so high so you don't end up having a seizure. If the stress of the infection is causing your blood pressure to go up, I might give you a blood pressure medicine. So when they said you're in hospital monitoring, what it says is you got someone there trying to keep you as close to a normal status while your own body is mounting an immunity, because we have no medicine that interferes with stage 3, which would be infectivity of the virus. That's why they were talking about those who have recovered. They're taking their blood and looking at the immunity that they generated and trying to find out, if you've had this virus infection and you lived, can I take something out of your blood serum and give it to this sick patient over here, and what you created can be used to defeat the infectivity in this other person.
Okay.
But we have no medicine against the virus.
Okay, I'll pause at this point. Once again, this is the Wisdom Table coming to you from the Grand Houses Community Radio Station, based in Harlem, USA. I'm Brother Leroy, co-host, along with others who may be on the line. I'm going to open it to the engineer, Brother Doug, or the other members of the Wisdom Table if you have any questions for Dr. Velva Bowl.
Yes, I do. Thanks, Brother Leroy. I got a question. I'd like to know from you, Dr. Bowles, what happens when you do hit the hospital? What happens when they're talking about these different types of ventilator machines and this thing about the peak? Because a lot of people call up and think that, 3 weeks from now, everything's going to go back to normal. Can you talk a little bit about what you see going forward with this?
Yes, unfortunately, it's not a matter of weeks, it's a matter of months. If you were to ask me to give a prediction, the way in which I would make the prediction is I would look at what happened in 1918 and 1919. That is the only case where we had a worldwide pandemic of a respiratory disease. They called it Spanish flu. It did not originate in Spain. Although in 1918, which is almost exactly 100 years ago, a viral respiratory condition swept through the world, not just the US, and 1/3 of the world's population died. We never found a cure for that virus. It simply went kaput because of death of the people. We are now in a situation of a virus that has become worldwide. This one seeded very fast because of air travel. Someone can be in China and then in San Francisco in less than 24 hours. They can be anywhere in the world and then at John F. K. New York in less than 24 hours. And the hotspots in the US show that travel was a contributing factor. because San Francisco airline system is proposed to be a place of entry. New York City, the two airports, the Giardia and John F. Kerr international airports. Look at Chicago, that's the OHAR, one of the most international airports. Look at Georgia, we're looking at Atlanta, one of the international airports. Look at Miami. So if you just look at where it's first spotted, then you would say, my goodness, it looks like it came fast and hard, but it came by plane. That would be a postulation. Someone was not sick, but had either gotten the attachment or the invasion, but wasn't feeling poorly, got on a plane, less than 24 hours, they have arrived in another place. So now the pandemic is here. I am, based on 1918, 1919 historical progress, will see this virus hanging on to the world for the next 12 to 15 months. It will, once we start to learn how to treat it better, because right now we're just doing Hail Marys. We don't really know the absolute treatment process. But once we get the treatment process, because ventilators are not the absolute cure. That's why people can even die on a ventilator. And we are doing Hail Marys right now. Whatever looks good, try it. Whatever we know already, do it. But as we are doing things, as a young ER doc that I saw speak most recently, he is saying this does not look like pneumonia, and the paradigm we're using to treat the patients should be shifted. I hope someone's listening to him and they are going to shift it so that they get more people surviving and the requirement of ventilators become less, but that's to be seen. To answer your question, I think that by May, you'll see what they call the leveling off. And they keep talking about it. You hear the governor and the mayor of New York talking about that. Leveling off means the rate of infection slows down. It doesn't mean the virus has gone away. I predict that June, July, August, we won't see as many numbers, but September is the natural season for influenza and other types of respiratory conditions. So I predict at the end of September, all the way through to Christmas, we're going to be back in bad shape. There are going to be a high incidence of infectivity. I hope we have a treatment paradigm, but if we don't, it will be a major die-off in the worldwide. It won't just be US. My caution and my reason why I go on different talk shows and TV shows to talk about it is I'm concerned about the Black American community. The decisions being made is without Black leadership input. It is clear now, and it's starting to be part of national news. The group that is dying the most are Black Americans. In New Orleans, we have 10,000 infections, and we have close to 3,000 people that die, and unfortunately, 73% of those who die are Black. Now, what that means is we got a high infection, Black and white, but the people dying are Black. And someone's saying, why is that? I said, I've been telling you this. It's because Black people do not receive the same level of health care as non-Black Americans. In these United States, we teach two different kinds of clinical care. If you are poor, unfortunately, many Southern Blacks are, and you are on Medicaid or some kind of assistantship, you do not receive the same medical treatment as rich people and people who have insurance. Consequently, if you have diabetes, you have access to 3 different medications, and someone with full insurance or deep pockets have access to 32 types of medication. If you are Black with diabetes, your chance of having a limb amputated is 9 times higher than anybody else with diabetes. Your chance of a heart attack is 3 to 4 times higher. Your chance for going on renal failure, I don't know the number, but it's much higher. Your chance for a stroke with high blood pressure, Why is that, Dr. Bowles? Because we are only allowed, if you're practicing primary care in the South, to write prescriptions that's on formulary. And you're saying, I don't know what this formulary means. It is a list of approved medicines. And these lists of approved medicines are usually generic or something that's been around for a long time. The newest, the best, the ones that we know can affect the most change are not allowed to be written to poor people. One of my frustrations is how badly compromised my medical training had to get in order to run primary clinics. That if I go to some highbrow pre-med, Harvard, Mount Sinai training, and find out the newest techniques, hear from the doctors doing the whole trailblazing, I'd come back to my primary care clinic and write that prescription for a patient that had been perfectly described. And I'll be told by their insurance or by Medicaid, you cannot write that script because it's not on formulary. And if they want it anyway, it's $400 a month. So the compromise, the frustration, why would I go and learn my continuing medical education units and understand new processes of development and know the science and come back and look someone in the face and treat them based on a 30-year-old or a 20-year-old process when I knew it wasn't the best medical standard in these United States?
Dr. Bowles,
Yes, sir.
let me just get this clear. Are you saying that there is a bifurcation of who gets what based upon how much money you have?
Absolutely. Not only how much money, but even insurance companies would dictate. If you saw you could have insurances as HMO, PPO, and all these different alphabets, if you're on one plan, this medicine is approved. If you're on another plan, this medicine is not approved. So consequently, the doctor no longer is prescribing medicine. I can sit there and give you everything I know you need, and have an insurance company come back and tell me we won't pay for this, and we won't pay for this, and we won't pay for this. Or I'll have a hospital come back and say, Dr. Bowles, let me send you a copy of our formulary because the medicines that you wrote are not on formulary. The physicians in primary care are not allowed to practice medicine when you're working with the poor. I have gone to my latest trip I went was Pri-Med in New York City, and it was a lovely presentation. They had holographic projections to train us. They did panel discussions, case studies, and one case study which fit perfectly to my group of patients, and the way in which a Harvard paid professor responded to the question of management was, I would have my fellow manage this patient because obviously this patient is non-compliant. I was so upset that I became disruptive. I stood up in the middle of this very austere professional and asked him, I don't have a fellow. And I'm here, my time to learn from you who is called the expert. And all you said is you would punt it with somebody else. In other words, they do not address the very problems that primary care doctors in rural, particularly Southern, I worked in South Carolina, Louisiana, so I'm not just banging on Louisiana, I've worked in these states in the South. If you do not have insurance, then the government will send you a formulary list. If you have insurance, the insurance company will tell you what they will pay for. So yes, not just a bifurcated case, it is institutionalized. If you are poor and you have a disease or a disease state, you are not receiving optimal care.
So Doc, now I've did this little reading, and I've read that the Spanish flu, the last time we had a worldwide pandemic, it lasted all the way into 1920. And
well, that's what I'm telling you. This one started October. COVID-19 was identified October 2019. That's why they gave it the 19 number. in October, there were reports that there is now a respiratory condition which appears to be serious, and this information was provided to the military and to the White House. No one took it seriously. In January 11th is when Wuhan announced that they were locking down their city because, but you notice when the young doctor came out and talked about it, they embarrassed him, they made him apologize, and what? 6 weeks later, he was dead. So he did not exaggerate. We, knowing what Chinese did in January 11th, we still had Mardi Gras here in Louisiana, and 1.5 million people came and stood in the streets of Louisiana on Burgundy Street and otherwise. So the country, United States, did not take it seriously despite the intelligence being available.
Now, Doc, I live here in Harlem, and I noticed, which is disconcerting, I noticed that I see people who are white walking around with no mask and no gloves. You know what I mean?
I think they're giving you a false sense of security. Whether you walk around with or without a mask or glove depends on how dense of a population. If you're standing out in the air and you're by yourself, what that's all about is they don't want you to contaminate somebody else. But if you are by yourself walking down a street and there's no one coughing, carrying on, or otherwise, you don't have anybody that you can infect, and you don't have the risk of an infection. So the hysteria about are you wearing a mask or not is kind of foolish. What you want to know is how close am I to someone else, such that if I get within 3 feet, I can contaminate them. And if they get within 3 feet of me, they can contaminate me. So a person walking alone down the street without a mask would not make me excited.
Okay. Now, what would be your opinion of how, other than the eating thing, what would be some of the other things that we as Black people should be cognizant with regard to the healthcare profession and when it's time for us to seek care or help?
Well, my first thing is we need a voice advising those who are making laws. The whole concept of social distancing, in my opinion, is a rich man's decision, because social distancing really means physical distance. And if they make a recommendation that you need to be 3 feet apart so as not to talk and fill the air with particles or sneeze or cough, many people, particularly in the Black community, live more densely than 3 feet apart. We can't go to the parlor or go to the basement or go to our den and separate from others. My concern is by not speaking up, we need to have Black leaders saying, okay, governor, okay, president, we understand social distances, but when you send Black people home and say, stay home, you are putting 8 adults in 1,200 square feet or less. Therefore, you are doing the same thing that happened on cruise ships. You are causing this group to be commingling in less than 10 inches apart. It's the same problem when people say, oh my goodness, what about the people in prisons? Oh my goodness, what about the homeless? I'm saying, oh my goodness, what about the poor? Here in Louisiana, we're hitting 90 degrees. A lot of people don't have air conditioning. They've closed the malls. I've talked to many of my patients who say they go and sit in the mall because it's cooler to be in an air-conditioned space because it's hot in their house. If no one speaks up and said, wait a minute, you give compensation for senior citizens, we need some compensation for poor Black neighborhoods. We need to open up some community centers. Why? They need the air conditioning. They need the internet. We need to stop sitting back and accepting someone else making decisions. Our homes are not conditioned to go home and sit it out. You can't sit in a house with 90 degrees plus, no air conditioning, and have 12 people in there. And if you require that and you mandate it, then you're not sensitive to the population you represent. So I'm calling out to the leaders of the community, speak up. We got community centers in Alexandria that are air conditioned and it has Wi-Fi. I'm saying we shouldn't just open them up to make a hospital or open them up for homeless. Open them up for poor people who do not have air conditioning. Open it up for high school kids who are not studying, who do not have Wi-Fi in their home. We need our neighborhoods speaking up for our neighborhoods. So it's not only are we at higher risk because our diabetes is poorly treated ordinarily, therefore we're at higher risk. Blood pressure is treated poorly, so we're at higher risk. But very soon, especially in the South, we will be crowded, meaning my exposure is higher, and it's going to be hot. So if we don't do some planning and stop sitting back and following the rules saying, oh, well, he knows best, somebody needs to speak up. If they say here, Walmart is an essential, then I'm saying community centers with air conditioning is essential in poor Black neighborhoods. That libraries are essential in poor Black neighborhoods that have no Wi-Fi and no air conditioning. Who's deciding Walmart is more essential than those things? And if we got leaders making decisions, what input are they getting from Black folk who are now dying? 73% of the deaths in New Orleans are Black. 68% of the deaths in Detroit are Black. 59% of the deaths in Chicago, Black. So we need to be talking now. We shouldn't be waiting to see. We need to be proactive and say, look, I understand why you want this, and that's a good idea, but in my community, I also need this. One size does not fit all in the United States. Now,
Brother Leroy, your mic is off, Brother Leroy. Oh. There you go. Go ahead, Brother Leroy. No, you're doing good. Brother Leroy's mic is off again.
Okay, well, my comment is, I think our Black leaders are failing us. There is no reason to come and knock on doors and go into neighborhoods and say, elect me. And now when we need a voice, the questions you're asking are very good questions. They're so important to be answered. And the politicians, I look at Governor Bell, I think he's doing a good job. He was the first one to announce that it is the Blacks who are dying at a higher percentage. And after he made the announcement, then it became a national thing where they started talking about Detroit and Chicago. But that says we have no Black champion. We have no one in leadership to say, okay, Governor Bell, let's talk about this. If we do special compensation for our elderly, here's what we need to do for our Black communities. We need to be proactive and not reactive. Don't get angry. Don't raise a fuss. Be proactive. Go and meet with your leaders and let them know what is good for the nation. I advocate you continue, but this is what is also necessary for my community. And that voice needs to be heard. It's not enough to say, well, we need to investigate it. Why don't you ask me? Don't you go investigate it? Ask the people who are in the middle of it.
Go ahead. Well, I mean, you saw that in the when they had the election just yesterday in Milwaukee. They had all of those people standing outside, waiting to go in the vote, and the head guy of the Republican Party, he had on PPE, he had on all the equipment that you needed. And he was actually went on camera and said, "Everybody's perfectly safe," and he had everything on. And all of the people standing online, they didn't have nothing.
But here's what I'm going to say. That's an overreaction on your part. Because
thank you, Doctor.
Let me tell you why. The PPE, when you see it, it should be. Now I can't say what happened in Milwaukee, but I'll use an ER doctor. An ER doctor knows that he's going to come in contact with somebody who's infectious. That is a given. That's his job. So that person should always be protected. a policeman who is doing riot control needs to be in PPE. Why? He may control 1,000 people and just one of them's infected, and he will get exposed by virtue of his job. Should everybody be walking around in PPE? No.
Oh.
So we need to have some common sense when we're looking at stuff and not overreact. I would not feel bad to see a voting registration person wearing PPE. Why? Because they're going to be interacting with probably 1,000, maybe 1,500 people. So they may just have one out of 1,000 who's infectious, but they must interact with them. So who's wearing face masks? Who's not wearing face masks? Who's in PPE? Who's not? They're splitting hairs. What we need to be asking is who is at the greatest risk? If I'm going to point out, and I was saying this back in February, when they were saying you can only get tested if you have a temperature of 104 and blah, blah, blah. Once you have symptoms, you know you're carrying it. But people who don't have symptoms may not know they're carrying it. So my recommendation at that time was, I want to have my postman tested. Why? He's touching my mail. And if he's infectious and doesn't know it, he's transmitting it. I want the cashiers in grocery stores tested. Why? Because they're touching my groceries. And if they don't know they're sick, they can make me sick. So instead of just testing those who had fever or those who had signs of infection, I'm saying first look at your work task people. Who are you requiring to stay in the front lines? Nurses, doctors, cashiers, janitors in the hospital, ambulance drivers, policemen. That is my front line to be tested. We shouldn't just wait to say, oh, well, one resident got sick and now we got 30 other doctors in quarantine. That is stupid. You've lost 30 people that could be helping others. So we're not going at this in a nice, strategic, structured, unified way. Test those who have the highest potential of infecting others first. I looked at how in grocery stores, they put these little panels up and these young people are still cashiering and they have on gloves, and I have to laugh. The glove protects the person who has the glove on. But if the person who has the glove on is touching anything that is infected, that infected glove will be transferring the particle. The people don't seem to understand what it is they're trying to do. Wearing a glove is not important. It's transmission. Even people with gloves ought to be using the cleanser every so often because you want to clean the surface of the glove. But no one seems to get the picture. They think if they have on gloves, everything's fine. If they have on a mask, everything's fine. And I'm saying, no, you're not getting it.
So there could be, you could just say there could be cross-contamination.
If I put on a pair of gloves and touch a contaminated surface, as long as I have those gloves on, everything I touch, I'm transferring the contamination. See, in the ER and healthcare, many times, especially with HIV, see, I was on the front lines as a medical student for HIV. That was in the 85 or 83 to 88. They didn't know how to treat and what was causing people to die. And I was in the front lines. I was wearing the shields. But what they taught us is you double glove. When you go into your patient, you have 2 pairs of gloves on and you do what you have to do. And before you leave the room, you take that outer pair of gloves off and drop them into the red bag.
Got it.
That means anything that was on the outer surface, I've now left it. And when I come out of the room, I'm still covered because I don't know what I'm going to meet in the hallway, maybe somebody on a gurney, maybe. So if you're not doing what they call infectious precautions, it's foolish to have on gloves, like they were saying, telling people to wear the mask 2 days. They don't understand. Whatever got on that mask yesterday, you can be spreading tomorrow.
Got it.
So we have to understand what we mean when we say protective. And it's not a game. It's not who's wearing it, who's not wearing it, and who got this on. It's not a fashion show.
Got it. I got you. Doc, you said something at one of your previous broadcasts. You mentioned something about diabetes being, I think you said it was more vascular than anything. And you mentioned about the high blood pressure medicines that you were talking about, like the Listerpril or whatever those things were, Lisinopril. Yeah, so can you just, as Brother Leroy would say, can you just go back a little bit and give us the 311 on the lisinoprils and what
Well, before we do that, let me mention diabetes again, because so many Black Americans are affected. Diabetes over the last 15 years or so has been redefined. At one time, we talked about high sugar and we treat it with insulin. Over the years, they've now seen that the condition of diabetes is much more widespread damaging than just how high your sugar is. In some medical settings, they are teaching diabetes is a syndrome, and this syndrome has a problem with inflammation. So you have an inflamed gut, you have an inflamed heart, you may even have inflammation in your kidneys. Now, the significance of that is when the body is chronically fighting inflammation, it is constantly using up certain nutrients. And when I mention things like vitamin D and vitamin C and zinc, those are types of nutrients that if you have a chronic disease like diabetes, you will, by definition, have a deficiency in certain nutrients because your body is constantly fighting inflammation and inflammatory responses. And that is why, if anything else comes along, whether it's influenza, flu, or COVID-19, you are more susceptible. And the reason that the people who have diabetes end up getting more amputations is that when your blood vessels are inflamed, you get reduced blood flow. So if you injure your foot or your toe and it doesn't heal and it gives a chance for bacteria to come and you get gangrenous green and you have to have an amputation, the reason is a diabetic's blood flow is not the same as someone who is healthy. So if we understand that if you have a condition already, anything else puts you over the edge. So if you can think like that, then you'll have a better understanding of why. See, what I don't like is in the language, when they first came out, they said COVID-19 affects the elderly and people with comorbidities. Well, who knew what comorbidity meant unless you were a medical doctor? And I had to tell in one broadcast, comorbidity is talking about you. Comorbidity, they already defined Black people at higher risk by saying comorbidity. So any group that has diabetes and high blood pressure and obesity, renal disease, dialysis, HIV, lupus, you are the population with comorbidity. That's what they're telling you, but they dressed it up in such a way that some people, particularly in the Black community, said, oh, Black people can't get this virus. The first time I heard it, I didn't know what to say because it's not that Black people can't get it. Black people be the ones dying from it. So when that rumor first came out and they were asking me, is it true? I'm saying, no, if any group is going to die, it's going to be Black people because we have more comorbidity. And what frightens me is I and some others know it and we can predict it and nobody's doing anything to stop it. When they first said it, elderly people and people with comorbidity, that's when they should have been saying, Black folk, your community is highest risk. Black folk, your community now need to be looking at how do we mitigate your dying first from this virus. But no one was saying that. And we were walking around believing the opposite.
What about the lisinopril? Get back to that.
I said, well, you're picking on one drug. Lisinopril is a good drug for some people. The reason in some cases that it's a problem, in particular Black people, number one is lisinopril is one of the few drugs on formulary. And what that means, we'll have a lot of Black people taking lisinopril. At one time, standard of care said if you were a diabetic, you should also be taking lisinopril. And they now say it's no proof that it helps anything. But at the time, the pharmaceutical companies had convinced the medical board that this was good advice, and consequently, everybody was on lisinopril. Well, to answer your question, lisinopril works through a mechanism that stops the secretion of a certain kind of hormone that's secreted in the lungs or slows the secretion down. And in doing so, angiotensin affects blood vessels. And if you affect angiotensin, then you can affect pressure. That was the mechanism. The problem is, and we talked a little bit about receptors earlier, there are people who can't tolerate what angiotensin suppression gives them. And that means some people will develop a cough behind any kind of pril, because lisinopril, acropril, there's a whole family of those drugs with slightly different names, but the last four letters are the same, PRIL. People can develop hoarseness, they can develop coughs. A few people can have an allergic response where their tongue swells up or their lips swell up. All of this is side effect, and we talked a little bit about side effect, is how your body specifically reacts to this concentrated, purified medicine, because pharmaceuticals are non-natural substances. They are taken from nature and concentrated. So if you happen to be on lisinopril and you had some kind of reaction like a hoarseness or a dry cough or shortness of breath, like I was telling you, any kind of comorbidity puts you at higher risk for not doing well if you should get COVID-19 infection.
Okay, so Doc, all right, thank you for straightening me out, because I was a little crooked on the lisinopril. So thank you, and the mask, and the thing with the mask. So thank you for that straightening, because we need to be straightened out, particularly when we're thinking crookedly about something. The last thing that I would like to ask you to do is to give, other than more speaking up, you talked a little bit about the food, you talked a little bit about the things that people should eat and how they should protect themselves, and you talked mainly about, and most passionately about, being an advocate for your community and the way that people eat and the things that are being done by the people who run our culture. Can you just wrap that up so that people, just one more time, because I think that was super important, and your passion was warranted about how we should be moving forward with this, how we should be looking to protect ourselves.
Okay, yes. As we move into the summer and people know how temperature affects us, and they're saying stay at home, which means you're crowded into a space that is much smaller than what social distancing was intended. The word should be changed to physical distancing, because what they're telling you, that if you are closer than 3 feet away from another person, I don't care if it's your wife, son, brother, sister, when that person speaks, not even have to cough, but speaks, if they are a carrier and they may not feel sick and may not know it, the spittle that comes off when we talk can have sufficient contamination of particles that if you are at risk, you can become sick. And if your immune system is compromised by any kind of other condition, a person who has no symptoms can make you sick and you can die. One of the things to protect yourself is to be at least 3 feet away from another person. Now, 3 feet away, if you're in school, wasn't possible because you sit next to somebody in class. So they closed schools. That makes sense. If you're on a train, you can't be 3 feet away because you sit next to somebody. They closed trains. So true about planes. But when they command that you must stay at home, we need someone saying, in my neighborhood, the houses or the living accommodations are so small that I cannot get 3 feet away from other people in my home. I can't sleep 3 feet away from other people in my home. That should not be ignored. If that is the case, and I know it to be true in poor neighborhoods where you have 8 to 10 people in 1,200 square feet, then accommodations should be made so that you can have social or physical distancing. And that's where, in a neighborhood where many people are in a small space, they should be opening community centers, opening church halls, opening libraries, so they can meet the government's decision of social distancing. Sending some people home is the opposite of what they intend to do. If in my home, I can't get 3 feet away from another adult who's in and out, then I am not social distancing. Then you tell me you're gonna give me a ticket, or you're gonna take me to jail if I go outside. We need a voice to saying, in order to meet what you have decided, you must open a community center so I can maintain a 3-foot social distance from other adults. And that's not being said. It's assumed everybody lives in a big house, and it's assumed everybody can separate inside that house, and it is not true. So talk to your leaders, and instead of being crowded in your house beside a huge community center, I'm not saying turn them loose to play basketball or whatever. You can have National Guard or whatever you want, but you need to let the people have that 3 feet apart, and not just close a school and say that, not just close a church. You need to be aware that by sending me home, if I can't do social distancing, you need to do something to make it possible.
Okay, Dr. Bowles, Dr. Velma Bowles of Louisiana. On behalf of Brother Leroy, I want to thank you for once again coming in and enlightening us on the things that need to happen in order for us to try to be more healthier. And most of all, letting people know that there's not going to be any 3 or 4 weeks around the corner and everything's going back to normal, because you hear a lot of that foolishness from people. And I want to thank you for coming on the show today. And I want to say, as Brother Leroy would always say, God bless you and God bless your family. And thank you so much for coming on, Dr. Bowles.
All right, thank you for having me.
You're welcome. And this has been the Wisdom Table at Ghcr.Nyc. And coming up next will be Community and Technology with my pal, my buddy, Mr. Stu A. Reed. The A stands for always. And they will come in and he'll have some of the regular crew, David and Lena, and they will come on and they will update people on the things that are going on now. So stay tuned for that. And again, on behalf of the communicators and Dr. Esther and all the other people from the Wisdom Table, I want to thank you for tuning in and being a part of the broadcast. And remember this: if you tune in next time, you just might learn something. All right. Good night.